All right, I think we're going to go ahead and get started. Looks like our numbers may be starting to slow down just a little bit. But again, just real quick, again, we will be going over the 5.21 data collection form that is posted on the STS website if you want to run out there real quick and take a look or download that and have available. So again, officially, welcome to the STS General Thoracic Surgery Database 5.21.1 upgrade webinar. Today is February 4th, 2021, and we are excited to start our walkthrough of the new data collection form. So with that being said, our welcome and introductions, obviously from the STS, we have myself and Carol Crone, Senior Clinical Manager for the STS databases. Carol will be conducting the DCF walkthrough for us. Also, we have from the STS, we have Addie Dolan, Emily Conrad. We also have Dr. Wormuth on the line for our surgeon advisor for today. Also, we do have our IQVIA colleagues on the line as well. We have Jean, Joe, Melanie, our usual suspects. If you do have a IQVIA related question, please feel free to put that in the Q&A. If you need to get that answered, IQVIA will respond to those to you individually. As again, today's session is going to be mainly dedicated to walking through the data collection form. And again, just as I stated, the 5.21 draft data collection form is now posted. You'll see it here under version 5.21.1. It's effective July 2021. And again, it's just the draft version with today's date. And I can walk for those of you that are not familiar with the website. From the STS homepage, just click on registries, click on STS National Database, click on the General Thoracic button, and under data collection, click Access Data Collection Resources. And here you have the 5.21 data version. So just click there, and that'll bring the drop down to the data collection form. All right. Let's see here. With that being said, actually, I'm going to turn things over to Carol now so we can begin our walkthrough of the data collection form. Carol?
Hold on, I have a couple things going on here. Let me just make sure.
Okay. Do you need me to stop share?
Nope. Let's see. Uh-oh.
Uh-oh.
Can you see my screen?
No, ma'am, not yet.
Yes. Oh, there we go. How about now?
It is starting to come up. Yes, ma'am, you're good to go.
Oh, good. Okay, sorry, everybody. Everybody's going to get sick. I had sick of hearing this. I having a little bit of computer issue, so let's see here. Okay, can you still see it okay?
Yes, ma'am.
Okay, wonderful. So first, I just want to make sure that everybody, if you wanted to pull this form up, that you were able to pull this up. If you still need a few moments, do you want to go ahead? And I think the raised hand function might still be available, and just let me know that you need a few more minutes to pull it up if you wanted to. Can you see the raised hand function?
I've got one person is working to get that up to.
Okay.
So, yeah. So, yeah, we have a few people that are pulling that up right now.
Okay. As those folks are pulling it up, again, this is it's posted on the registry. It just got posted late this morning. There's one form that's posted up there right now, and that's the form on the right, which is the blue and green highlight form. And this is the form that will be posted along with the clean versions when we have those ready to go. The form on the left is the form that we used for the upgrade calls, and it will show you the removed fields, the changed and moved fields. We're not going to post that just because it gets confusing, but we are happy to share it. So if you'd like a copy of this, maybe just put your email in the Q&A box, and we'll be able to send that to you after the webinar today. A couple things to note, we have on the left, the yellow fields will be the fields that are removed. When you're looking at this and you see things like race where it says white Caucasian, and you see underneath it says race Caucasian, that's yellowed out and scratched through. It doesn't mean that we removed these fields, but we made this a multiple select field instead of individually having to select each race yes or no. So you'll see like the yes or no grayed out or yellowed out, but you'll see the blue over here uh, with the checkbox available. New fields that were added or new additions like these boxes will be highlighted in blue. So you can see here that we added in fields of city. The other thing to note are the green fields are things that were moved with inside the form, which are, for an example, it would be like this patient postal code. We just moved it from over here to up here, and you'll be able to find it somewhere in the form. We're still just verifying that we had it highlighted correctly. So this is just a draft on the left, but pretty close, near perfect. The other item that we provided for this upgrade, which will be available in the form that's posted online, are these double red asterisks, which are which note that an item is a risk model variable. The importance of the risk model variables is monumental when it comes to adjusting the outcomes for your sites. So these are the fields that all fields are important, and we expect you to answer the questions for each field, but the risk model fields are those that you really want to make sure that you double check or triple check to make sure you're abstracting the correct information. Age and race or age and gender aren't major ones, but when we get down into the risk factors, those are a little bit more important. So we'll send out the left form after the webinar today, but if you provide your information and you'd like a copy of that, we'll do it after the webinar in one big email to everybody who requests it. Okay, let me see here. So hopefully, Mary, hopefully you have the form pulled up. All right. So let's get started and we'll go through, you can feel free to ask questions. We're going to walk through the form starting with the very beginning all the way down through the end. I'm going to try not to skip around any, just to make sure that we, cover everything sequentially. If you have questions as we're going through, please make sure your questions are related to the areas that we're reviewing. Probably spend about 20 or 30 minutes going through the form, and then the rest of the time, depending on how many questions there are, we'll go over to questions. If there's not a lot of questions, then we will continue going through the form. So the first section is, so just to give you a little bit more background, this version will go live on July 1st. So that means that OR dates starting July 1st, 2021 and after will need to be collected on this version 5.21. The vendors have the data specifications. We are working on providing them with the software specifications within the next week. They then will get certified and they will be then working with your site to update your software package or if you're cloud-based, updating that to get you access to the new data version. You cannot submit cases that are prior to July 1st on this form, and you cannot submit cases that are July 1st or after on the current current form. So let's get started here. I already see quite a few questions. Can you, Leanne, would you mind just answering live the ones that put their email addresses in so those are saved?
Yep, absolutely.
Okay, thank you. Okay. Alrighty, so we'll start here. I'm going to pretty much I'll go back and forth between both of these forms. We'll start on the right side. We're in the demographics section. We added a couple questions here. One is the parent to the Social Security number. Is it known, yes or no, or patient refused? And if your site chooses not to provide that information, either no or patient refused is acceptable, we'll provide clarification in the training manual. We're expecting the training manual to be available hopefully no later than mid-May, and then we'll be able to share that with you as well. It just takes time to go through and make sure we have everything correct in there with the core group and the surgeons. So again, a field to open up the Social Security number. Then we added in for geocoding, patient street, city, state, region, and country. We moved the postal zip code up here. Some sites are not allowed to enter PHI down to the street address. And that's okay if you do not, if your site does not allow to enter that, but it really does help us with geocoding and looking at socioeconomic factors related to lung cancer or esophageal cancer. For instance, if we see a high prevalence of lung cancer in industrial areas, this is how we would be able to identify that. So it's really helpful if we are able to get this information so we can do some more granular research with it. But again, if your hospital does not allow you to provide PHI to the registry, that is okay, but not preferred by STS. And then we get down into race. Race was made into a multi-select field, so you do not have to answer yes or no, you know, 6 times. You would just answer this parent field. Here is the race documented. And if you said yes, the race is documented, then you could choose more than one race. The race is a risk factor. So, and I'm not sure in the general thoracic risk models if there's more than one race that has an increased risk. But if there is, it would the risk would be associated with the race that has the highest risk. So that's just a select all that apply for sites that are pulling out their own data or have their doing things with their data outside of pulling it out of their vendor software and using it internally. You would no longer be looking at the short name and sequence number. You will be looking at harvest codes to pull those out. And we are providing the harvest codes and sequence numbers, all that information in the training manual. So we'll go over that when we get the training manual ready towards May. The next section is the admission section. We made a couple changes here. We'll go again, admission status, and then the payer. Within the payer section, we have primary payer is on the left side of the sheet. Secondary is on the right side of the sheet. And we added just some language in here and then got a little bit more clarity, similar to what you'll see in the adult cardiac. If you're abstracting for adult cardiac, where we have the commercially managed options. We will do a session on what commercially managed options Medicare plans are. Once we get through the walkthrough, we'll be able to focus a little bit more on education for some of these specific variables. But essentially, commercially managed Medicare plans are when patients forego the plan Medicare Part B, and I believe it's Medicare Part C, which is the commercially managed Medicare plans. They forego that and choose to opt into a commercially available plan like Aetna or Blue Cross, and it would say managed care. So we'll go more into that in future education because it can take up a whole session instead of taking up time here now. So if you select Medicare, then the next question is it a commercially managed plan? If it is, then you're going to skip right down here, and the question is, does the patient have Part B? If it is not a commercially managed plan, then you would provide the HIC or MBI number. This used to be the Social Security number on the Medicare cards. They're removing, if they have not removed them all, they're in the process of removing all Social Security numbers from Medicare cards, and they're issuing cards with HIC number or MBI number. So that would be the number on the card that's not the patient's Social Security number. And if yes, what is that number? We use this for Medicare for linkage with the Medicare data. So it's important if you're able to provide this to us that you can do that. Now we can look at longitudinal outcomes that way. So our insurance options, non-Medicare, and then if Medicare, you have to answer these questions. And then we get down into Medicaid, military health, commercial health insurance, and HMO, non-USA plans, or other. We removed a couple options and added this choice in of other. Indian Health Services, correctional facility, state plans, and other governmental insurance. These had very, very low frequencies, so it was not helping any for us to have to get that granular. So if the option is not here, then you're just going to choose other for these. There are some hospitals that have a large Indian population, And for those hospitals, you can choose other, but you can also work with your vendor to add in a specific field if you're interested in collecting that Indian health insurance specifically. And then we get down to uh, surgeon name, NPI, tax ID, hospital name. No changes there, all pretty much the same. So far I only see, let's see. Oh, that's the chat box. I don't see any questions. Okay, great. So we're going to keep on going here. Then we're going to get down into the pre-op evaluation. And there's quite a few changes here. When we were doing this upgrade, we worked really closely with the surgeons and some members of the core group to try to come up with the best way to collect this data with decreasing burden on sites, and trying to find a balance between that without losing the granularity of the database or the robustness of the data that's collected within. So a couple changes that we made here, we will add in, I see the COVID, I don't know if the COVID field's here, Leanne, or if it's going to be someplace else, but we will still add back in that COVID field.
Yep, I'll get
So
that.
yeah, that's okay. So we'll still be collecting COVID data. It'll be the same question about the laboratory confirmed diagnosis of COVID. And if they did have a positive test, what was the date? So that will also be added in, and we'll repost it. If there's any other changes, we'll put all those changes out together and repost it. Then the next question that was added in here is the calculated BMI. This is not something for you to calculate. This calculation will be provided to the vendors, and they will calculate this using the height and weight. So this will auto-populate for you within your vendor software. The next question is a little bit of a change. We had a previous question about, did the patient have a previous procedure? And we kind of switched that up a little bit, because what the surgeons really wanted to know is, did the patient have a prior surgical history in the planned operative field? So if they had if they're having a lung procedure, did they have a previous lung procedure? Or if they had a hiatal hernia before, did they have another procedure within that same field? We will provide clarification within the training manual. As I said, we're still working on that. But just to clarify what we were looking for, this is really worded a little bit better, and hopefully will make good sense when we get the data back. And then we're going to look at, we've removed this unintentional weight loss over the past 3 months. But within when we get down to the esophageal cancer section, because really that's the patients that we're most interested in about this weight loss. When we get down to that section, you'll see a question there related to a percent in weight loss, just a little bit more specific and specific to that population and specific in definition. So we will get down there in the esophageal cancer section related to that. Then we get into the cardiopulmonary history. Nothing was really super removed here. We did remove this valvular heart disease question, but because we have kind of switched it out a little bit. So I'll show you what that looks like. We added in the option of none. So for this section, we have pre-op, history of cardiopulmonary disease. If there's no history, all you do is click none. If they have a history of any of these, then you will go ahead and select which ones make sense. It's a check all that apply. And if they have a history of CHF, then this child will open that's asking for the ejection fraction. Hypertension and coronary artery disease are risk factors along with CHF. So, and then you see the valves here as well. Okay, vascular history. Just kind of cleaned it up a little bit. We added in, this used to just be major vascular disease. We added in aortic or peripheral related to vascular disease. So you would collect both of those here. And then again, the option of none if the patient has a CVA was their permanent neurologic impairment. And it looks like we got rid of the neuromuscular disease section. I guess we would be capturing that on the patients that it was relevant to regarding myasthenia gravis. within the procedure section. So then we get into the endocrine. Let me see here. Okay, and then we get into the endocrine GI renal history section. No real major changes, just again, the select all that apply for that. And we get into the cancer history. Same thing. We just did a little bit, we got rid of this completion date for the thoracic radiation therapy. And I think, Leanne, this one is a select all that applies. So, right, yeah, so I see it. So we have, so for history of cancer, coexisting cancer, pre-op chemo or immunotherapy. And if you check this, this is a select all that apply. If you check, say you check this one, there will be checks here so that if you check none and coexisting cancer, obviously that wouldn't logically make sense. So there will be checks there in your vendor software. So that is not allowed. When you get down to, say you check here preoperative chemotherapy, immunotherapy, then the next question that pops up would be when and for what disease. This too is a select all that apply. So you could select any of these options here that are relevant to the patient. This prior surgical history, we move that down to a different section and you'll see it below when we get down there. Preoperative medication history, check all that apply. No real changes there. Preoperative testing. And no changes there. PFTs, pretty much the same information. Let's see here. Okay. Preoperative testing and then psychosocial history. We just did a little bit of difference here, kind of aligned it a little bit better with what we're collecting in adult cardiac, so our databases can align on the definitions and what we're studying. So we have cigarette smoking, smoking history, pack per year, and if yes, what are the pack years? This is specific to general thoracic, and then we get down to the substance dependency, abuse of non-prescription medications or illicit drugs, and then alcohol abuse. These questions you'll see we added in an NQF measure at the end, just like for those of you who are abstracting for adult cardiac, it's the same NQF measure that looks, it's an all or none measure. And if the patient screens positive for substance abuse, dependency of non-prescription medications or illicit drugs or alcohol abuse or smoking, they have to be counseled on the appropriate positive screen. So that will be explained. I think it's NQF 2527, but it's down below, and I don't want to. I might be wrong on the number, but I'm pretty certain that's what it is. So if you check any of these, then the appropriate screening has to be given, provided to the patient. And that the definition of appropriate screening comes from CMS because it's actually one of their core measures where they screen for substance abuse and alcohol abuse. Appropriate screening is using a tool that is like a validated tool for purposes of screening. No real changes here. Dementia, living status, functional status, ECOG. ECOG is expected on every patient, so we do not have an option of, well, I mean, remove the option of choice of dead, but we do not have an option to leave this not available. ECOG scores are expected on every patient. If you're not getting those from your provider, you need to work with your provider to make sure they start dictating those. We will also be coming up with surgeon worksheets this is one of those items that we will include on the surgeon worksheet for you to implore your surgeons to use. Okay, we had some major cleanup happen down here. We had a lot of duplicates, kind of redid the order, cleaned it up. And what we're looking for is the primary, and we are not collecting the secondary disease. So it's just the primary diagnosis. And it is just, will just be a pick one. So no more secondary diagnosis, just the primary. We remove some of the duplicates. We have primary diagnosis up here. And when you get down, these are for the major procedures. So lung cancer, esophageal. These would be lung cancer, main bronchus, carina, and that means that these are not, this is not related to metastasis. This is related to a primary tumor. So this is where you would collect that information. Further down, you would be able to see the metastases options down here, lung tumor, metastatic. So again, these choices up here, these are related to primary locations of tumors, and we will do more education on what that means, what's a primary versus a metastatic, and how do you know when you're looking at a surgeon's note or surgeon's consult, how to read that correctly to get that information. So just quite a bit of cleanup. You'll see a lot of yellow. It's not because we removed these choices, it's that we were probably double capturing them somehow. So to clean up the database a little bit, this is actually one of the reasons why there was a delay in the release, is we just went through and made sure that we weren't really double capturing anything and that things were labeled correctly and clear. We did add in a couple new, like this malignant neoplasm of thymus, just some clarifying language. So we have lung cancers, esophageal, thymoma, thymectomy, myasthenia gravis, and mediastinal mass. We just clarified that the section is related to all of those. The trachea, and then the diaphragmatic hernia and GERD. These next are usually done, these are usually not the primary procedures or primary reason, not a procedure done that's intended for analysis. So these might be something else that are done. Usually that procedure would not be analyzed. So we have the cardiovascular, chest wall, diaphragm, esophagus, other, lung, other. Let's see what's in the Q&A. Okay. And then we pleural, tracheolarynx, trauma, and then miscellaneous. And then if there's something that's not listed here, this is where you'll free text in the diagnosis list and the free text and then the ICD code. The ICD code are these R06.02 or J95.812, things like that. Can I get a raise of hand if folks want me to continue on or if we should stop for other questions right now? I know we have other things going on too besides the upgrade, but I don't want to miss an opportunity. So if you'd like me to continue on with this, please just raise your hand and majority will win.
Looks like they're going.
Oh, I guess. Okay. So only, I mean, is that all we can do is 40 hand raises? Okay.
Okay.
So I guess we can stop it. The majority don't want to continue on. So we can stop here. You can lower all hands. Okay. Because the next section is the operative section. And we get down into the analyzed procedures, and I really want to take some time on this. We have about a half an hour left. How about this? How about folks that do not want me to continue on, if you could raise your hands? Sorry to be wasting time raising hands and lowering hands, but I'm not sure if the count stops at 40 or if it's legitimately only 40 people. Well, it's 40 to 6, so I guess we're going to continue on. Okay. Is that okay, Leanne, Dr. Warmuth, or whoever else is on the call with me?
Yes, ma'am, that's fine. We do, okay. Yes, that's fine with me, Carol.
Okay, so the next section is the operative section. This is where you're going to collect the information related to the procedure that's being performed. We have regular information, date of surgery or entry, exit, anesthesia start, stop, and procedure start, stop times. If it spans through midnight, then you would select the multi-day operation. Elect status of operation. I don't know that it's just elective that's used in the risk model, but the status of operation is used in the risk model. My guess is it probably includes all of these are looked at to determine increased risk. The planned stage procedure and reoperation on the left-hand side that are coded in green, those are moved down to a further section, and we'll see those in a little bit. The surgical approach conversion, we had some procedures are normally include in approach conversion, and that's normally part of the procedure. It might not be dictated anywhere. It's just understood that that is part of the surgeon's plan going into the operating room. We added this word here, unanticipated surgical approach conversion, because we added the word unanticipated because what we're really looking for is more or less, was there a surprise during the procedure, and did the surgeon have to convert with it being unplanned? So that's really what we're checking here. We'll clarify this in the training manual, but this approach, you would be able to identify this through usually the surgery note. You would notice that something went AWire, went wonky in the procedure, and the surgeon had to make a decision to change the approach to complete the procedure safely. And then we added for unanticipated conversion type. So not conversion type, but unanticipated. Again, there are procedures where it is part of the procedure to do a conversion. What we're looking for here are those that are not part of the procedure, where it's really unplanned and it's more or less something went sideways during the procedure and they had to make a quick decision to perform that procedure a different way. We added other here just because if there's another reason outside of vascular anatomy or lymph nodes. Under unanticipated surgical approach conversion, it's VATS to open, robotic to VATS, robotic to open, and no. And then we get down into the ASA classification. And then we get into the procedure type, procedures performed.
Hi, Carol, sorry to interrupt, before we get to the procedures, can we, Sam had a question regarding the primary diagnosis section, the category of disease. Can we address his question?
Sure. Sure. So Sam's saying for primary diagnosis in pink versus blue, are the blue diagnosis only captured when done in conjunction with treatment for a pink diagnosis? Leanne?
I'm sorry, I was on mute. I apologize.
That's okay.
So that, I'm sorry, I'm looking at, my brain is in procedure mode.
It's okay. Let's pull up the training manual and see what we say here.
Yep, sorry. I was totally thinking procedures there, Sam. Sorry about that. I was getting ready to say. Other blue diagnosis only captured when done in conjunction with treatment for a pink diagnosis. Let me, Carol, I'll research and we can come back to that if you want.
Okay.
If you continue. Yeah, let me confirm, because I'll go through and take a look and I'll confirm.
Okay, that'd be great. Yeah. I think that we collect only the one diagnosis, but yeah, it's good to double check, Leanne.
Absolutely.
Okay. And then Mary's asking, will elective and emergent under an unanticipated conversion be defined in the training manual? Mm-hmm. Yeah, we'll clarify what's elective, what's emergent. It's really difficult, and I'm not sure we left elective in there. I'm sure the surgeons had a reason for doing that, but we will clarify with them when we work on the training manual as to what do they mean by elective when we're looking at unanticipated. So what is an elective unanticipated conversion? And yes, we will we will clarify those in the training manual. For the next section is you're going to check all of the procedures performed, and then you're going to circle the primary procedure, select the primary procedure out of all of the procedures performed. We are putting checks in here, and we'll probably, maybe this is a good place to stop, because this is where I don't have it ready, and I wanted to show you what these checks are going to look like. But for example, if you said that you are, they're going to be weighted. Dr. Wormuth, are you there? Because I know that you're going to be able to explain this much better than I can explain it. You're waiting. I'm not sure if he's there or not.
Yeah, he had stepped away for a few minutes.
Okay, that's okay. So what we've done is we've weighted some procedures. So esophageal cancers, procedures, resections have a higher weight than lung cancer. Lung cancer has a higher weight than hiatal hernia. Hiatal hernia has a higher weight than tracheal, and tracheal has a higher weight than thymus. And all of these procedures have a higher weight than the minor non-analyzed procedure. So if you choose, and when you check all of your procedures and say that you code an analyze a lung cancer procedure and you code an esophagectomy, the esophagectomy has a higher weight. So that should be coded as your primary procedure. And there will be warnings that come up in your I know definitely at IQVIA, I'm not sure if we're going to be able to implement it in the vendor software or not, but it's going to give you a heads up that you're coding the wrong primary procedure and that you need to go back and update the primary procedure. And I'll be able to pull up the sheet once I have it. I don't have it ready right now. I apologize. I didn't think we were going to get this far. So but again, you're going to check all the procedures performed. You're going to code the primary procedure. We'll provide instructions on what to do when you have more than one procedure coded and how you determine what the primary procedure is for that. But essentially, you'll look at the weights, and I think we should probably add something in on the DCF so you're aware. So it's kind of like a reminder when you're aware. Now we have the analyzed cases. These are marked on the left. These cases are cases that are performed for primary lung cancer. So not a metastasis and not a not primary tumor. Sorry for the double negative. So the next section is the concomitant procedures, and these are things like this is a therapeutic wedge resection, which means that this is not being performed. A therapeutic wedge resection is not performed for a primary tumor, but you would code this in addition to the primary procedure code. So you might do lobectomy and a wedge. You would code both of those, and the lobectomy would be the primary procedure on that patient. We can do some more education specifically on coding of primary versus all procedures and how to determine that. But I think that we're going to stop here, Leanne. I would rather have Dr. Wormuth on, and I would like to show the weighting. I'm not sure if we've finalized all of that yet with IQVIA or how that programming will work or where it will be implemented. So instead of getting ahead of myself and having to go back and correct the information I share out, I think it's probably best to stop there.
I agree. It looks
okay.
like, is Dr. Wormuth back? I'm not sure.
I see him, but that's okay. We can stop here. It's probably a good spot. We have 20 minutes. Maybe we can get through some questions. And if there's no questions for the upgrade part of this, we can, answer IQVIA questions.
Sounds like a plan. Sounds good to me.
Yeah. Okay, so let's go to Nancy's question. She says, when will the thoracic risk adjusted reports be ready in IQVIA? Do you want to take these questions, Leanne, or you can go ahead and take them, and I'm here to help if you need me, okay?
Yeah, so we are working to get that general thoracic, the spring and fall reports out as quickly as possible. IQVIA again is in the process of getting these dashboards. These dashboards have been created, and actually we are QCing those at this moment. So our goal is to finish our user acceptance testing, and we'll push that out to the beta testers, our core group UAdders, for their review as well. And once that is complete, we will push that out to the general thoracic community. Obviously, we are working to get that done as quickly as possible. and hoping to have all of that information, the spring and fall reports, within the next couple of weeks. So we really do appreciate your patience. We know this isn't ideal, and I know, we've said this over and over again, but we really do appreciate your patience and know that this type of delay is not expected moving forward. So again, just please hang in there with us, and we are working to get that data out to you as quickly as possible. Do you have anything to add regarding that one, Carol? All right, let's see here.
Sorry, I was muted. I was just saying, no, we've already spent hours reviewing it. We're working with IQVIA daily, going through and fine tuning it.
Yeah, let's see here. I see a few clinical type questions. Carol, what do you think about this? I don't know if we're able to go ahead and answer this one regarding COVID pneumonia, the first one from Mary.
Yep. So Mary's asking if a patient has COVID pneumonia after discharge, but within 30 days of surgery, do we count this as a post-op event pneumonia? It should be counted as pneumonia, but this is where you're going to answer that that patient is positive for, did have a positive COVID test, and these patients will be removed from analysis. We'll report back separately on the COVID patients, but they will not be counted towards your mortality or complications post-surgery. I hope if that answers your question, Mary. If not, let me know and put something in the Q&A so I can answer it further.
Let's see here. Mary had another question, maybe for next time. If there's only wedges done for lung cancer, do we still code that as primary, no lobectomy performed?
Yeah, the answer to that is if it's a primary lung cancer tumor and a wedge is performed, that you would still code that as primary.
Yep. Let's see. Nancy had a question. Where's the readmission data fields? And in the report, and then don't recall seeing for lung cancer. I'm not sure I understand. If you could clarify, Nancy, that would be helpful.
Yeah, which report are you referring to, Nancy? And which report are you referring to? Where's the readmission data fields in the report?
She's talking about the IQVIA.
So you're talking about the unadjusted, because they're the unadjusted reports. They should be in on the dashboard, and also under the missing variables section.
Right.
Okay.
Okay. Let's see. The next question for Tammy. I completed DCF for every case that my surgeons are primary on. How will I do, say, a bronch? Do I have to complete all of the medical history, etc.? Internal, that's up to you all, correct? Carol, correct me if I'm wrong. Is that correct?
Yeah, I'm not sure what's been historically done, historically said, but it's not an analyzed case.
Right.
However, submitting, I think the expectation is that complete data is submitted to the database. So if you want to collect it, we ask that you complete the data collection form in its entirety where it makes sense. Yeah. But again, I don't know how it was answered in the past. So
yeah, I agree with you, Carol. Obviously,
okay.
Yeah, because you're correct. We do encourage, obviously, to complete all the data fields for the database. But again, that bronch would not be would not be analyzed. But I would think, you would obviously we would want you to collect that data. Mary says we collect non-analyzed cases on the non-analyzed form. We won't have those two forms moving forward. We're going to have the one data collection form. So yeah, we will not have the two data collections and forms. We won't have a minor procedures only data collection form. Did you want to add anything to that, Carol?
No, it's just going to be one form.
Yeah, those two forms cause having two separate forms like that caused a lot of confusion in the past, a lot of confusion. So moving forward, as with the other databases, we'll continue to have just the one data collection form.
Yeah, I do want to show though, if you are doing a bronch and it's not for lung cancer, you don't, you can still answer out the pre-admission history. And this information is important if we ever want to do do any type of analysis on bronch patients, even though they're not analyzed. This information is still very helpful. I know it's a lot just for a bronch, but it is helpful if you are going to collect them in the database to be complete in your data that's collecting. When you get down to the operative section, you're going to code that bronch, wherever it may be. Bronchoscopy under whichever one it is here. And then when you get down here to choose the op type, you're going to code, you can still code, if there's a laterality, and then you would just code no to all of these if they're applicable. So you would just code no because it's not a lung cancer, primary lung cancer. And then you wouldn't have to answer any of the questions, obviously, under these sections here. So you skip all that stuff. And then you could answer the post-operative events. And again, this is just, it's really helpful if you could provide the complete information. I think it is part of the STS contract with sites that if you're going to enter data into the database, that it's complete. So.
Great, thank you. And of course, one of the most popular questions is the 5-year follow-up ending with this version. And the answer to that is yes. There is no longer follow-up with this 5.21 version. Obviously, if you've been collecting that 5-year follow-up previously, we encourage you to continue to collect that data for the previous version, as we need to finish out that version. So again, that's just recommended. But yes, that 5-year follow-up is ending. There is no 5-year follow-up with data version 5.21.1. Let's see here. Thus, Mary saying, thus we only fill out the suggested fields, so we're able to choose the fields which we want to complete for non-ALS cases going forward. And I think Carol just elaborated on this. We encourage you to collect all those fields that are appropriate for those cases.
Yeah, hopefully it's all no, and the patient doesn't have any complications, and it's just a real simple data collection for you.
Correct. Okay, please clarify. Okay, sorry, just going through questions here. If index procedure is an outpatient procedure and patient is readmitted within 30 days as inpatient, does this count as a readmission since first procedure was not inpatient? Are you scrolling through?
I don't know. I have no idea on that one.
Yeah.
I think the answer is going to be probably, but I don't want to give the wrong information. So is it in the training manual already? We can pull that up and check.
Let's
okay.
And too many windows open over here. Sorry.
That's okay. Let's see.
You do the same.
Yeah, and I only have my one computer screen, so it's a little.
Okay. Yeah, Katie. Thank you, Katie. Katie says
oh, good.
It has to be an inpatient status to answer the readmission question. Thank you, Katie. Yep, Mary. Thank you.
I was wondering where our core group members were at. I thought we invited. Hold on. I thought we invited Katie and our friends over to the panelist side. I guess not, but I just did.
Okay, I was getting ready to do the same thing. Sorry, Katie and others. Sorry about that. Okay, that was answered. Okay, so the tracheal resection, thymectomy, etc., are no longer optional with detailed information. It was that esophageal and lung were required, but the others are not. So, Tammy, that is correct. The primary lung cancer and same as always, the primary lung cancer and primary esophageal cancer cases are required. Those other, the tracheal resection, hiatal hernia GERD, all of those other parts are optional. So
they're optional, right? They're optional, but if you're going to enter them into the database, then we really want you to enter complete data on them. So they're optional to submit, but if you are going to submit them, then we would really like to have complete data.
Correct.
Okay.
We still have to follow up with hernia cases 30 days and 1 year, and I believe that information is still in this version.
Yeah, we haven't gotten down there yet.
We haven't gotten down there yet, so we'll talk about that once we get that far. Same thing there. Please clarify what cases need follow-up. Right.
Okay. Any
Um,
questions for IQVIA? I think we have our IQVIA team on the phone. So if we have any questions for IQVIA, we can. Oh, we lost Melanie, but I see we have Jean and Joe.
oh,
So her computer may have dropped. If we have any questions for IQVIA, or if you're having any other questions about data collection, we can try to answer those. Otherwise, it looks like we're doing pretty good. And maybe we can end a little bit early.
yeah, if you have any questions, just please put those in the Q&A.
Whitney's
Oh.
raising her hand. I can unmute her and see what she has to say.
Sure, let's do it.
Are you there, Whitney?
You may have to unmute yourself. Looks like you're muted on your end. May have been a mistake.
Okay.
Let's see here. We do have some more questions coming in. Is the deadline still March 5th for harvest? So yes, the harvest close dates are posted out on the website, and I believe that one is still it's still set for March 5th. And again, that is collecting data through 12/30/2020. Obviously, if there's any change, we would obviously let you guys know. But yes, that deadline is still set for March 5th.
Oh, here's one for IQVIA. I uploaded and nothing shows on the critical summary report. Does it mean it checks out? IQVIA team?
Hi, this is Joe. Yeah, if there's nothing in your critical summary, that would tell you if there were any critical errors. It tells you the number of records that are accepted. So if you're not seeing anything there, then you are good to go.
Great, thank you.
Let's see here.
It says, I'm sorry, I am just looking for clarification. If we put all our cases in now, analyzed and non-analyzed, will we have to put all the data in for a bronch or any previously deemed non-analyzed case? So we're asking that if you are going to enter the non-analyzed cases into the database, that you provide the complete data, including the risk and outcomes of those patients. Not just that a bronch was done, but that you provide complete info on those patients.
Okay, let's see here. Our next question, so we have another question from Nancy. How can we check that our hospital name and MPI numbers match up with our submission? Where in the report do we have this? I don't think this is available within the IQVIA platform, Joe.
No,
I don't think so either.
Yeah, I don't think so.
I don't know that that they display, but your PID number should match up. And if you want to verify what was linked to that, you can reach out to the STSDB, db@sts.org, and verify that, Nancy.
Perfect. I'm not showing a number of records accepted on the critical summary. Heather, are you saying you don't have any records on the critical summary report, or?
Yeah, I would say so. There's 3 columns in the critical summary report. One tells you the number of records that were in your file. Another column tells you the number of records that had critical errors, and another column tells you the number of records that were accepted. And then actually there's a 4th column that tells you the number of records that were skipped because they were already in the system with no updates being made. So there, you should see those 4 columns of data in the critical summary report.
Okay. Carol, looks like Sabita has her hand raised. Do we want to?
Sure. Yeah, let's see what.
Oh, you lowered it.
Lowered her hand. Lowered her hand.
Okay. Nobody wants to talk to us live today. It's okay. Our feelings aren't hurt. I'm not seeing any additional questions. I do have, I will make a distribution list of every one of those that you all sent your email addresses in to share the all markup document that Carol is showing on the left-hand side of the screen. So I will get that information out to you. Let's see.
Oh, that's a good question. So the question is for the social security number, is it okay to enter 99999.4321, or do you want the full social security number? It's really better if we have the full social security number, because when we do the linkage with the national death index, this is one of the variables that we do to verify that the linkage is correct. So if you are, IQVIA does not store this number, but we do use it when we have the data come over from DCRI. So if you have that number, it would be good if you could provide it to us. If not, I don't know if, okay, good. Thank you.
Yep. All right. That's all that I have. Again, I will get that form emailed out to you all. Just, I want to go through, I know Carol and I are going to review it again. So give me
I think it's okay. It's okay to send out, Leanne. Sure. Yeah. It's just that we just have to note it's in draft form. So
Yeah.
it's not perfect. It probably never will, because there were lots of changes. So
Okay.
it's not perfect, but it's a good place just to review and
Yeah.
And use it for your reference.
My eyes are crossing looking at that thing. I've looked at it so
Yeah.
much.
And if anybody sees anything, wonky is my new word, because I've been watching NCIS and Abby says wonky a lot. So that's my new word. But, sorry.
I love it.
If you, but if you look at on the version, under the STS, let me see if I can pull it up here for you all. Let me close out these other screens. Under the STS homepage, if you go here, where Leanne showed earlier, the STS registries, national database, general thoracic, and then the access data collection forms. And if you review this draft form and you see anything that isn't quite making sense, now is the time to let us know, because the vendors are still building it. So it's better if there is an error that we went through it pretty detailed. We were meticulous in going through it, but it's a big form. And of course, there's rooms for spelling errors or mistakes or whatever it may be. It's good if you could just put your eyes on it, review it, and let us know what, if you find anything, or even ideas for next upgrade. That's always helpful too, which is in 3 years. But so
Yeah.
please take your time, take an opportunity to review it, because we're stuck with it for 3 years. So we want to make sure it's in a good position for you all when you're abstracting your data.
Right. And so just email me directly with anything that you see, or suggestions, anything that needs to be corrected. Just email me directly with that, and I can get that information fixed, and we can discuss with Paul and all that fun stuff. So if necessary. All right. It looks like we are at time, Carol.
Okay.
Thank you so much for walking through that form today, Carol. I greatly appreciate it. You're a pro. I know you did it with adult cardiac, so I appreciate that. If anyone has any questions, again, please feel free to reach out, and then we will continue the upgrade webinar on our next. Actually, let me, if you want, I can share my screen to finish up these.
Yes, ma'am.
These slides, if I can figure out how to do that. I have too many things.
We have technical issues. Leanne and I have just been having technical issues all week. Sorry,
Yeah,
guys.
It's been a struggle. We've definitely been riding the struggle bus for sure. All right. Okay, so here we go. Just real quickly. Again, my contact information to share your thoughts, any corrections, anything you see that may be an issue. Again, just email me directly here at ljones@sts.org. And then our next, our upcoming webinars, we have our thoracic monthly webinar on February 10th at 1:30 Central. Our next upgrade webinar is February 24th at 2:30 Central. And again, we have our March monthly webinar on the 10th, on March 10th at 1:30 Central. That's all that I have, that Carol has. So again, thank you everyone for joining. We appreciate it. Thanks STS colleagues and IQVIA, core group, Dr. Wormuth, we appreciate it. And we will see you guys on our monthly webinar on the 10th next week. Thank you, everyone.
All right. Thanks, everybody. Have a great day. Take
Thanks.
care.
Bye-bye.
Bye.